We learn a lot about how to recognize child abuse and intimate partner violence, and I think elder mistreatment deserves that same level of attention. For me and my classmates, I guess, as future physicians, will all care for older adults or communicate with them in some capacity. So I think recognizing where abuse exists, neglect maybe, caregiver strain, and also the effects of ageism should simply be included as part of providing good patient care.
Welcome back to the NCA podcast, Conversations on Aging and Justice, and our series, The Evidence Exchange. Today, Dr. Gary Epstein-Lubow and Laini Tuboku-Metzger explore how mentorship shapes careers in medicine and elder justice. They also discuss why elder mistreatment belongs in a medical curriculum and share how curiosity, collaboration, and systems thinking can prepare the next generation of physicians to care for older adults. The two first met through Laini's externship with the Education Development Center's National Collaboratory to Address Elder Mistreatment, where Gary became her mentor. Since then, their mentorship has continued to grow, with Gary supporting Laini through her Master of Public Health Studies at Brown University and into medical school. Dr. Gary Epstein-Lubow is Professor of Psychiatry and Human Behavior, Professor of Medical Science, Professor of Health Services Policy and Practice at Brown University. He's also a geriatric psychiatrist and a national leader in dementia-related research and policy. Laini Tuboku-Metzger is a graduate of Brown University's Master of Public Health program and is currently at Morehouse School of Medicine. Through her work with Education Development Center and other public health organizations, she's contributed to research, policy, and programmatic efforts addressing aging, reproductive health, and chronic disease management. We hope you enjoyed this conversation.
Gary, you've spent much of your career improving the lives of older adults through clinical care, dementia research, and national policy efforts. Looking back, what first drew you to this work, and how did elder mistreatment become part of your journey?
I'll answer in just a moment, but since we're just getting started, I just want to say how cool it is to have this opportunity to do this podcast with you, because it would be so lovely if people could have recorded in on the conversations we've had multiple times from the beginning of when we met, and you were interested in things related to your public health degree. From a mentorship perspective, just really satisfying to see the development of your thinking over time, and to have this chance in this podcast to talk with you about your steps into becoming a medical student and how elder mistreatment has been a formative part of that. So vulnerable elders have been a concern of mine since I first did my postdoctoral training and my initial work as a hospitalist. And actually been doing some of that work this week again. And I remember the same thing from way back then, that there are patients that end up in hospital settings where I work as geriatric psychiatry inpatient. And it's discouraging to see that there are things that could have been done before the hospital to prevent it. And that there are experiences of mistreatment or experiences of not being supported in as well as our health system could have, or not supporting the families as well as our health system could have. And that years ago led me to working on national and policy solutions, mostly focused around dementia care, to find ways to get better dementia care to people in the community. And as part of that work, I met colleagues at Education Development Center and began working with them in two areas, one on dementia services, and then another related to responding to elder mistreatment. And the elder mistreatment work, it was under and still is under the auspices of the National Collaboratory to Address Elder Mistreatment. And when you and I met, I had these wonderful colleagues at the National Collaboratory to Address Elder Mistreatment that I was really enthusiastic about you meeting them. I now have a question for you, Laini. This is before your externship with Education Development Center and during and before your MPH training. Much of your work had focused on reproductive health, health education, and diabetes care, not necessarily aging or elder mistreatment. So, what drew you to this opportunity and what surprised you the most about working in aging and in elder justice?
Thanks, Gary. And I also have to say something about how I am so appreciative to have you as a mentor. I never expected, the opportunity at EDC to turn into our mentor relationship, which I hope will be something that, lasts my whole career. And to answer the question, so before working with EDC, much of my public health research focused on disparities that exist in reproductive and women's health. So through that work, I learned that conditions like uterine fibroids, PCOS, and endometriosis affect millions of women, yet they're often underdiagnosed, underfunded, under-researched, and simply just not talked about enough. And that really shaped the way that I think about public health and also sparked a passion for bringing attention to issues that are often overlooked. So I actually found out about the EDC externship through one of my MPH courses. It was called Measuring and Improving the Quality of Healthcare. And as part of that course, we all had to complete a semester-long quality improvement externship, and we could choose from a long list of projects. And because the course was taught by a gerontologist, many of those projects focused on aging. But what kind of set EDC apart for me was that you guys were bringing together researchers, clinicians, and policymakers and community organizations to actually translate evidence and research into action. And what surprised me most about working in aging and elder justice was just how overlooked aging can be as a public health issue. We all know that our population is getting older, but I don't think I fully appreciated how many aspects of healthcare and society are affected by that until I started working at EDC. So I think it's really a common thread throughout my growing career. I'm really drawn to health issues that have enormous impact on people's lives, but don't always receive the attention that they deserve.
So cool, Lainey. Very well described. Can you say a little bit more about what you were doing with the externship when we worked together and some of the products that you were part of?
So I had the opportunity to work on two really meaningful projects with EDC. The first was helping to organize a national policy convening, and that brought together more than 70 experts across the country to discuss how we can improve the prevention, identification, and also response to elder mistreatment. So I got to help with the literature reviews prior to the convening, planning some of the logistics, and developing background resources for participants. And then the second part of that project was actually contributing to a book chapter on public mental health policy and aging. And that part of the book chapter that I worked on focused on ageism. So that looked like looking at current policies, identifying gaps, and also thinking about ways that we can build systems to better support older adults. And that project really taught me that improving health isn't just about discovering treatments, but sometimes it's about changing those systems, policies, and attitudes. So I went from kind of knowing not a lot about it to knowing kind of the intricate details and policies uh, that go into something like ageism. And also on a personal level, this work connected with my own family's experience. When I was in high school, my grandmother was diagnosed with glioblastoma, and watching my family provide around the clock care definitely showed me how deeply patients and caregivers depend on one another. And it also made me appreciate how much support families need during serious illness. So, working with EDC expanded that perspective. It really helped me to understand the policies, community resources, and also the multidisciplinary teams that make an enormous difference for patients and caregivers.
Awesome.
So, my question for you now is you have worked as a physician, researcher, mentor, and policy leader. What have you had to learn through that process or maybe unlearn about addressing elder mistreatment?
Great question. So I'm learning all the time about all forms of abuse and neglect and the importance of prevention and detection. I need to lead with that, the importance of prevention and detection. So the place where I've focused my attention and been building my learning is around the complexities of self-neglect and ways to bolster or strengthen a person's skills and capacities for self-determination while they are encountering new cognitive problems. So again, the big issue about prevention, detection, it interweaves with this concept that I'm working on all the time about self-determination in the context of self-neglect. And I've done some work a couple of years ago around the research topic of goal concordant care and how people who are living with cognitive symptoms or family caregivers, what a term like that might mean to them, goal concordant care, and having someone be able to self direct their wishes for their life choices. And all of that is just constant learning for me about how to interweave the rights of individuals when they're at risk for self neglect and the importance of prevention and detection. And then I think I have a question for you. Many people think of elder mistreatment as a niche topic. What do you wish more students or early career clinicians understood about why this work matters?
So I think I wish people realize that this isn't just someone else's issue. Aging is something that every one of us is moving towards, and almost everyone will either become an older adult or care for an older adult that they love. And one thing that I came to realize through this work is just how common something like elder mistreatment is, yet we rarely talk about it. I also learned during the policy convening that healthcare professionals often miss opportunities to recognize it simply because they haven't been taught what to look for or what to screen for. So I really hope that medical education continues to integrate these topics, not just as maybe one lecture, but throughout training. We learn a lot about how to recognize child abuse and intimate partner violence, and I think elder mistreatment deserves that same level of attention. For me and my classmates, I guess, as future physicians, will all care for older adults or communicate with them in some capacity. So I think recognizing where abuse exists, neglect, maybe caregiver strain, and also the effects of ageism should simply be included as part of providing good patient care. Think my experience overall at EDC and learning alongside a physician like you, Gary, and a researcher and mentor really expanded my understanding of what it means to care for older adults. And it really taught me that it's not just about treating disease, but recognizing when abuse is present and how to support caregivers, understand community resources, and also advocating for systems that help people age with dignity, like the ones you just talked about.
Awesome. You're really a rock star, Lainey, as a student, as a medical student, as a public health clinician now. And I just really like how you just described the importance of including elder mistreatment throughout medical training for all of us. So, um, thanks.
Scary. You guys really opened my eyes to what it even looks like. I didn't even know what something like adult protective services was. I think we hear about CPS, child protective services, so much, but it's like there's a whole another end of things that exist, and that is really important too. So I guess that leads into my next question to you. But what is a question that you wish people would ask about elder mistreatment or about the work in your field, but they almost never do?
I thought a lot about this. So I phrased it in a number of different ways. And the first one is a question I would like to be asked, but I don't get asked. How do I balance the strains or the personal discomforts that I feel when serving as a witness or a helper or a clinician for someone who has been mistreated or abused? And I asked it some other ways also. What steps do I take for self care? What do I think all of us could do as clinicians and advocates to build in supportive infrastructure for those who would choose to use them to support the personal metabolizing of grief, loss, and the challenges that come with doing this work together? So, not everyone would take advantage of that type of environment. I notice it in my clinical work that it's not there enough. And then maybe that's because of me and sort of how I do my own processing of the challenges of working with people in these very difficult situations and having to really be there for them, for their suffering and the mistreatment that they experience. I would like to be asked more about how do I balance that? How do I metabolize that? And just, well, I'm curious for your response to, because this is the first
Well,
time you're hearing what
the question. Yeah, well, I think it's a great question. Now I'm curious about your answer, what your answer to that would be.
I think the first thing that I do is just notice that it affects me, is that I have some mental awareness in the moment when I'm listening carefully or learning about someone's tragic experiences, that I'll have an awareness that this is very difficult for them and it's difficult for me as a witness. And it's my job in that moment to take care of myself so that I can be present for them. But so that's just the first step, is noticing it myself. And then noticing afterwards if I'm reflecting or I'm writing a note about it or I'm following up to help with an intervention plan, I'll notice again, does this affect me? Or how does this affect me? Then there's some choices about whether there's another team member who I'm working with who may also have been affected by this, and would we combine the planning that we do to support the person and their family with a debrief that we would do with each other about just acknowledgement of this is a very difficult situation. I have had, for a hospital critical incident, there have been formalized team meetings where there's like a case presentation and an opportunity for everyone who was working to discuss it. And that can be overly formal, like not necessarily a part of my own processing of the work being challenging, but having something that was less formal like that, that would be like a weekly team rounds, would be something that I would see as beneficial for me, not for everyone. So again, I would support people having choices for making their own decisions for how they would metabolize difficult situations. Then there's sort of the big picture things of overall work-life balance, where for me, exercise, meditation, adequate sleep, social supports from family, those types of things that sort of keep my life running, also end up being relevant for me to be able to recharge and then be present for the next situation. But I wasn't anticipating answering the question. What I was wondering about is, when I raised that question for you at your stage, having the experiences that you've had with EDC and in other community outreach work that you've done, and you're learning about the challenges that people face related to abuse, and you thinking about yourself in medical school, does the question resonate for you?
I think it really does, and I think it's something that we should probably think about more. And obviously, I'm just starting out in medical school, but I have my first exam on Monday, and even then, I've had to take steps to be like, okay, like I need to make sure I factor in some room for self care and time for family and all of those things too. And I'm sure that what I implement now will later become the building blocks of how I deal with some of the hard situations and maybe some of the hard patient encounters later on a much larger scale, obviously. But that's why I was curious to hear what your answer would be to the question, because it is something that I think about. And I think your answer really humanizes healthcare professionals too, because you do so much, your research is so expansive, you're obviously an expert in the field. But at the end of the day, it also affects you too. And I think that's something that everyone needs to think about more.
You should feel empowered and free as a student to raise your hand when you're in clinical environments. That's part of the teaching I do with medical students, that there can be hesitancies. Worst case situation, it feels like it would be threatening as a student to ask a question. But for something with this type of sensitivity, like
Mm.
the medical team is working with a very difficult situation, an abuse situation or a family crisis situation. If you can find a person in your team and you can say, hey, I'm a student, I'm learning, this is difficult. How could we as team members process this? You should feel,
Right.
hopefully you're invited by the team leader to do that. If not, you should feel empowered as a student to be able to ask someone on the team for that.
I really appreciate that, and I'm sure it's something I'll think about once I encounter those situations because they can be heavy, and sometimes I feel like people can brush past it or just expect you to process it all on your own. So you've encouraged me to think about becoming what you call a physician plus. What does that mean to you?
It's a physician who thinks about systems. So historically, medical training has included two sort of meta components. Basic sciences like physiology, pathology, and biochemistry, and clinical science like the practice of internal medicine or dermatology or surgery. So when I went to medical school, that's what there was. Basic science for 2 years, clinical science for 2 years. We had a little bit of like public health in the first couple of years as like part of basic science. In the current era, many are advocating for and building a third meta aspect of medicine that has been termed health system science. So basic science, clinical science, and health system science. And a physician plus is trained in all these basic clinical and health systems. You have a lot of that already from your MPH training, ability to think about populations and an illness across populations. It's more than that. It's thinking about the social determinants of health, how those impact an individual patient or how they impact a community, and why there might be more diabetes in a particular community or more hypertension in a particular community, and then approach that from a population health perspective. So the physician plus is there in the clinic, knows the basic science, knows how to diagnose and treat medical conditions, and thinks about the health system and can include quality improvement projects, approaches for innovative solutions, being an early adopter to new population-based approaches.
But I do want to say you are the first person who introduced me to the, I guess, term physician plus. But I think it really does encapsulate what I'm most excited for and what I love about combining medicine and public health. It's that it always extends far beyond like the walls of a hospital or an exam room. But I think I'm the most excited to be a lifelong learner. I love asking questions, doing research, and ultimately like finding ways to improve healthcare at the systems level. So whether that's through like health policy or education initiatives or community partnerships, I definitely want to continue to build skills that allow me to advocate for patients beyond just those individual clinical encounters. And that's definitely one of the things that I learned during my time working with you, Gary, and EDC is that some of the biggest improvements in health happen when clinicians and researchers and policymakers and communities work together. So that's definitely the kind of physician that I hope to become is somebody who provides excellent patient care, but also helps to improve the systems that care for entire populations.
Awesome, awesome.
So, Gary, what do you now know that you wish someone would have told you when you first started your career?
My answer to that is that families are everywhere. So let me explain that. This is more about where I wish there had been added training early in my career, in addition to someone just saying that obvious issue early on that families are everywhere. So during medical school, I wrestled with whether to do residency training in family medicine or in psychiatry, and then when I was doing my psychiatry training, with whether to do child psychiatry or community psychiatry with people who have chronic mental illness in the community. And then I eventually chose geriatric psychiatry. And through all of this, I was always attracted to how a patient's family and their social supports are part of the navigation of the health and illness. And it's why I've done a lot of work focused on supporting family caregivers. It wasn't mentioned early enough in my medical training that family members are really everywhere. And no matter what someone chooses as a specialty, having a sensitivity to families and to communication skills, it's important for working with them. It's important to effective healthcare. It's important for prevention of elder mistreatment. It's important for addressing elder mistreatment when it's identified. And having those skills of working with families and knowing that we can't provide healthcare and social services without having skills for doing family-based work. I wish someone would have told me earlier, and I wish there would have been opportunities to have training related to that really from the beginning. If a college or graduate student listening to this podcast decides to learn more about elder mistreatment because of this conversation, what would you want them to know?
So I would encourage them to start by looking around their own community. Elder mistreatment is not just a definition in a textbook. Older adults aren't just patients. They're our grandparents, our parents, our mentors, our neighbors, and really the people who help to shape our communities. I think once you start paying attention, you realize how many opportunities there are to support healthy aging and advocate for older adults. And I would also encourage students, especially those going into healthcare, not to think that they have to become geriatricians, almost like you were saying, to make a difference. But no matter what specialty you choose, you'll care for older adults in one way or another. So definitely learning to recognize elder mistreatment, understanding available resources, challenging ageism, and advocating for better systems are skills that every healthcare professional should have. And most importantly, just stay curious. I came to EDC expecting to learn about health policy and make a good grade in my class, but what I didn't expect was how much it would shape the kind of physician I want to become. I left with you as an incredible mentor, Gary, a new perspective on aging and caregiving, and a much deeper appreciation for what it truly means to care for people across the lifespan. So if this conversation encourages even just one student to learn more about elder mistreatment, I hope they discover what I did. It's not just a geriatrics issue, it's a healthcare issue, and every one of us has a role to play.
Incredible, Lainey. Thank you. It's been lovely to be supportive of you throughout all of the
You've been
planning.
the biggest support. I couldn't even begin to describe it. I had no idea that this class was going to give me such a great mentor, but you've always just been so supportive.
You make it easy. And yeah, very satisfying for me to see how your careful, thoughtful, sort of implementing your curiosity into plans have manifested in you getting started in a challenging career with the brightness and enthusiasm that you've brought to all of the work that you've done. So look
Thanks.
forward to seeing more. Sure.
Thank you.
Thank you for listening to the Evidence Exchange. If this conversation made you think of a future or current healthcare professional, please share this episode with them. We'll see you next time.